home office here in Andover, Minnesota. And I want to thank you for joining me for another Facebook and YouTube Live. And I hope you're enjoying the summer. That is just for many of you, it's coming to a close with classes beginning in the fall in just a couple, 3 weeks for those on a traditional calendar. And it's just great to be with you. And just want to put your name in the chat. Let me know where you're from. I'll give you a shout out as I see your name in the chat. And my name is Keith. And if you are not familiar with what I do, I'm the founder of Keith RN. And my mission is to create innovative tools to develop clinical judgment so that our students are better prepared for both practice and licensure, including Nextgen. But my greater passion at the end of the day, it's really to serve, to shepherd, and to support the needs of nurse educators any way I can. And so the blogs that I've written, the books that I've written, even the faculty guide that I've just published and I'll make mention of, and that's kind of the inspiration for today's topic, really is my best effort to just strengthen and guide the development of clinical judgment so that our students possess the competency and the skills of clinical reasoning to be better prepared for both that practice as well as licensure. And so, today we're going to be talking about clinical judgment in the clinical setting. A lot of us struggle with the tasks and the skills and the med pass and all that we're doing. But how do we develop clinical judgment best in the clinical? And what do you need to know as an educator to confidently develop clinical judgment and clinical reasoning skills in your students? So I want you to put that in the chat here so I can kind of, as I look to my left, I can kind of keep my eye on that and let you know that I can answer those questions as we work through them. Now, this is part 5 of a 7-part series on clinical judgment that'll take us all the way through the school year. And these Facebook Lives live on both my Facebook channel, Keith RN Think Like a Nurse, as well as my YouTube channel, Think Like a Nurse. And so again, easy to remember. If you're not subscribing to either one of those social media channels, you'll be first in line to see new content, new videos. This series, for example, of clinical judgment, I have taken the time to create some really concise 3- and 4-minute videos on every topic that we've talked about over this series. And I'll highlight here in just a moment. It's on these channels, especially my YouTube channel has the 3 to 4 minute need to know. So if you're looking for just a real concise, you don't have to spend 40 minutes watching the Facebook or YouTube Live. You can watch the YouTube channel. And Amy put that in the chat. We got a playlist of these of this series that, again, part 5 was just posted this week. And so, yeah, it's great to have Destiny with us here. Carol is staying up past her bedtime. Now, she must be on the East Coast because it's only 8 o'clock Central, Carol. So I hope that you're getting some well-deserved rest. And got Rich in Florida, Joyce in West Virginia, boy, Abel, and Shelly in Texas, Destiny and Virginia Beach, all around the country. This is a blessing and so excited to have you all with us. But I can't see much without my cheaters. So let me keep an eye on that. But, I just want to highlight just in 2 minutes, just what we've talked about over the last few weeks, because it's really important, because these lay a foundation that, yes, you can watch the clinical judgment Facebook tonight and you'll get some great information. But let's go back to part 1. We talked about defining clinical judgment correctly. Why that's important, because clinical judgment is an outcome, not something you can teach directly. So if you're unclear about defining clinical judgment, please go back to that. And there's a lot of confusion within nursing education today. There are some well-known educators who have publicly stated that clinical judgment is the doing that comes after critical thinking. That's really not, that's a misunderstanding. Clinical judgment is really the doing that comes after critical thinking is really the clinical reasoning and the clinical reasoning skills of noticing, interpreting the data, responding and reflecting. And so really the judgment itself is the outcome. The doing is clinical reasoning. And there's a lot of confusion, and I want to help us as educators teach it well so that we understand it well so we can teach it well. And, part 2, we talked about frameworks to teach and develop clinical judgment. And I talked about very briefly how nursing process and Tanner's clinical judgment model are evidence-based frameworks that we've been using for a long time. Tanner is a evidence and research-based framework since 2006 in the nursing literature. And there's a lot of educators, well known, who advocate using the NCSBN model in the 6 steps of Nextgen. But we must remember that that is a test model. It has never been research for practice. So therefore, why are we wanting to make that the framework, the theoretical framework to guide our teaching and our curriculum? Let's use Tanner. Let's use best practices. Let's use these evidence-based frameworks. And, even Phil Dickinson at a recent conference that I attended communicated very clearly that the Nextgen framework of the 6-step model, it's a supplemental framework that should not be the main dish. He publicly acknowledged that. So I am really baffled why there are some who really advocate that it should be the foundation of our curriculum. It's like, no, let's focus on Tanner and nursing process. Part 3, we talked about case studies and the evidence for using case-based curriculum and case-based learning. And again, bringing context to our content was one of the key findings of Dr. Benner's work from the Carnegie Foundation. And so bringing context there's nothing better than a well-written case study that emphasizes clinical reasoning. And then last week, we talked about clinical judgment in the classroom and how we need to put our content on a diet. There's a lot of advocacy within nursing education say, got to make room for active learning, flip the classroom, active learning. But how many of us are drowning in infobesity with our slide presentations? We're teaching too much information, and many of us are struggling to put our content on a diet. And, before I go on to tonight's presentation, I received an email recently from an educator that highlights this dilemma. And she says this, I'm struggling with so much information. How can I cut the amount of content from my PowerPoint slides so I can focus on what is most important and make time for your skinny reasoning case studies? Do you have a strategy for identifying the most important information to teach? And, I've shared this at conferences where I've presented, and I'm going to keep it really simple. But, this question is worth answering because many of you who are listening have the same question. And in essence, what I want to start with is that, remember, we're teaching first-year generalist nurses, therefore not specialists. Let's keep it to what a student and a new nurse is going to see in that first year of practice, not the obscure or specialized, kind of content that's really more for those specialty areas. But what is first year generalist? Second, let's remember of what's most common to practice. There are problems, there are the exemplars that we use in a concept-based curriculum, or as it relates to the problems in a traditional curriculum. What's most common? And what's most common in your community that your students will become nurses in? What's most common to practice? What are the most common medications, the most common lab values that are relevant to first-year generalist practice? We can't teach everything because our students see everything equally important as novice nurses. So it's our responsibility as educators to filter that content. And so just something I just wanted to highlight and just basically, communicate to you. We also need to remember too, as this educator mentioned in it, she said in closing, I want my students to love my course and be excited to come to class. I want to grab their imaginations and inspire them. Doesn't that capture your heart as well? None of us wants to be teaching a bunch of students who look like zombies. You know what? There's no joy in that. there's no reward or satisfaction. We want to engage them. And I just want to encourage you that when we implement educational best practices using Tanner's framework, active learning case studies, getting them participants, adult learners that your students represent, they're looking for relevance. They're looking for, how does this relate to real world nursing practice and that need to know information? And that's where a concise lecture, as well as active learning that emphasizes clinical realities like a well-written case study, can do that. Adult learners also value small group work and the application and problem-based learning that case studies and other practice-based problems represent. And so I really want to encourage you to really use those principles of adult learning theory and educational best practices as well. And so let's get into tonight's topic. And we're going to be talking about strategies to develop clinical judgment in the clinical. And, like I've said before, this is a dialogue. We got a chat box. And you know what? I just want you to know that, I'm going to do my best to multitask. I don't do that well as a dude, but I will do my best to keep my eye on the chat and look at some of the questions here. And so, Rich says concept-based curriculum helps reduce content saturation. And Rich, you're spot on. That's one of the really, I think probably the primary strength of a concept-based curriculum is that it does decrease content load. But we need to bring context, Rich, to the concepts. So be sure you're using those rich exemplars and bringing that application to the concept-based curriculum. And so, and as you look at that, and Carol says, yeah, students are spending hours looking up meds the night before clinical. And, Carol, I would say, what medications are they looking up? Are they looking up? We need to know kind of, obviously our patients are on numerous medications, but let's even focus on, Carol, on what's the need to know of pharmacology. And I've said this in other settings, but it's basically, if your students can understand and know the mechanism of action of the class of the medications they're administering, they can deductively reason using their understanding of essential knowledge to identify the most common side effects of that medication, as well as the nursing implications by just knowing one thing, the mech of action. Think of a beta blocker, atenolol, lopressor, labetalol. When you understand what a beta blocker is blocking, you'll know you need to check your heart rate and blood pressure before you administer. And you need to know, obviously, what's the most common side effects? You guessed it, bradycardia and hypotension and orthostatic hypotension. We'll throw that in for good measure. So again, as in the clinical setting, if I were just to kind of maybe build on what we're going to be talking about in developing clinical judgment, remember that we must lay a knowledge foundation that is based on practice and the most important aspects of practice. And so pharmacology, I'll go to my deathbed saying, if you only need to know one thing, like a triage, as a triage nurse, that in the ER where I've practiced in the past, what's the triage of pharmacology? Mech of action. So anyways, yeah, and Rich says you're doing that, so awesome. Great job bringing concepts and context to your concepts. So let's keep going here tonight. And, as we talk about clinical education, I think it's really important that we recognize that there was a recent article that came out in the Journal of Nursing Education in 2021. And Amy, I want you to put that link in the chat. But Leighton came out with an article titled Traditional Clinical Outcomes in Pre-Licensure Nursing Education, an Empty Systematic Review. And what they found out, Leighton and her colleagues found out that there is no evidence, zilch, to support how we do clinical right now in nursing education. There is no evidence to support the traditional apprenticeship model of one faculty and 6, 8, or 10 students in the clinical setting. In fact, some of her conclusions were that she has serious concerns about how educators are assessing learning in the clinical environment, that we're focusing on hours. Let's kind of not focus as much on hours, but focus on competencies and evaluation of the skills required for clinical practice. And one of those foundational skills, you guessed it, clinical reasoning skills. And we'll be talking about that here shortly. So stay with me, because we're going to make Tanner and operationalize her steps and look at how we can strengthen clinical reasoning skills. But what's really interesting is that, as many of you know, the AACN Essentials just came out for undergraduate nursing programs. And they're talking about competencies as their foundation. That's really the big takeaway from the Essentials. It's all about what your students can perform, taking knowledge and using it in action. That's the essence of clinical reasoning, by the way, that thinking in action. That's the core competencies, and that's the essence of what competencies represent across all the domains and all of the concepts that the Essentials addresses. But, you know, I want to encourage us as educators. The lack of knowledge of what really works in clinical teaching, let's use this as an opportunity to develop the knowledge. So there are many of you who are master's prepared educators. You're looking for you're thinking about your doctorate, a DNP, a PhD, whatever it may, EDD. You know what? Let's develop the knowledge. Let's be part of the needed change. And so I want to encourage all of you who are either in the position to do research or are looking for a research project in pursuing your doctorate. Let's look at what works to develop clinical judgment and the thinking in the clinical setting, because we have no evidence. That is a big problem. But let's be part of the change, and let's make a difference, and let's start doing the research from right now. Let's not let, this was just published this year. Let's not let that continue, and let's keep going. So anyways, let me just see if I've got some things in the chat here. Thanks for putting that link in the chat, Amy. And Kayla says, yes, I'm a brand new clinical instructor, and I hate the idea of students spending most of their time on the computer looking things up. We need to be out actually doing skills. And actually, Kayla, we need to do both, because navigating the electronic medical record is a skill, a competency that even the Essentials says our students need to possess, and how to quickly collect the data. But let's not make that the focus. We need to do both. We need to do the skills. And I agree, Billy, it's also the thinking that goes with the skills. Because as we know from the NCSBN and the work that they've done, 50% of the skills that a nurse does in practice relate to clinical judgment. And it's the thinking with the skill. And that's why if we're in skills lab, which isn't the focus of today's content, but that we must be bringing context to the skills that we're teaching. So one of the things that I've done, for example, with my case studies, I created a variety of assessment and when it comes to skills, like with the catheterization, what do I see in practice where a nurse needs to think to use a urinary catheter or to straight cath? You guessed it. Bladder retention or urinary retention in the post-op patient, and using a bladder scan, looking at those signs and symptoms of retention, using a case-based scenario. That's basically found in the membership, by the way, with numerous other cases on additional skills, because I recognized years ago, we got to bring that context to the content, especially with our skills. So yeah, great information, and thank you for sharing that. So, you know, for those of you that are not teaching baccalaureate programs, I would love you to look at the ACEN Essentials, the core competencies for professional nursing education, because let's just be real, professional nursing education is not just for the 4-year level. I'd love to see our 2-year programs embrace the essence of the essentials. Even practical nursing programs can glean so much to strengthen practical and vocational nursing education. So Amy's got the link for the ACEN Essentials. That just came out this year, about 3 months ago, I think. Let's read that. It's about 60 pages, but it's light reading and it's good reading. Let it inspire you to look at some of the competencies, because what I want you to recognize is that the key concepts that we need to integrate in nursing education, especially in the clinical setting, are clinical, the first 3 out of the 9, clinical judgment, communication skills like SBAR, nurse handoff report, and compassionate care. So you know what? That's all happens where? In the clinical setting. So we've got to operationalize these concepts and really apply knowledge in nursing science in the clinical setting. And so just some thoughts. I'm going to see if I have any specific questions here. And Karen just wrote a case study to go with our initial skills: IV med calc, sepsis protocol, central line care, current. Would you be willing to share? So Karen, if you want, if you've got a link that you could go to Amazon and create an S3 link, or do something to share that, or send it to me at keith@keithrn.com by email, and I'll be glad to post that on our next Facebook chat. But thank you for sharing that, Karen. That's wonderful. And so you just got to clean it up. Okay, I see what you replied there. But yeah, go ahead and send that to me. And I love, this is the fun thing of going to conferences. And even a Facebook Live is a second best, in my opinion. But you know what? Let's network. Let's collaborate. Let's share our stuff. That's why the Facebook group that is the admin for, developed 3 years ago, that Teachers Transforming Nursing Education, really is a collaborative, supportive community to do just that. Well, let's get started. A lot of good information, but let's keep going. When we talk about clinical teaching, we must remember the foundation of clinical judgment and professional practice is caring behaviors. This is why educators must understand and integrate Tanner's framework and model of clinical judgment, which she published in 2006, Thinking Like a Nurse. And Amy, if you can find that link of the PDF of Tanner's original article, it's a must read for every educator, because what Tanner said, what Chris said 15 years ago, and this is something that's really profound, but it's so true. She recognized that in order to think like a nurse must first care like a nurse. Because what Tanner recognized in her synthesis of over 200 articles in the nursing literature back in 2006 that is still timeless and relevant today, because Nextgen borrowed extensively from Tanner's framework, and I've talked about that. That's in the prior videos, is that clinical judgment, the noticing, or the recognizing cues, if you want to go with Nextgen model, is prefaced on the nurse's caring and engagement and the empathy that they possess in the practice setting. So in other words, let's just be honest, your biases and assumptions. And if you're just not that caring and you're not that engaged in the patient, you're going to miss things. And that's basically, we can all recognize when you make a judgment or assumption, or you just don't care, you're not going to notice. And if you do notice, you're going to minimize it. Say, oh, that pain, they're just drug seeking. When it's actually a complication that's developing. So let's remember that caring is foundational to clinical judgment. And it's kind of like the filter. Think about caring in the clinical setting. It's the filter that really influences how the data is perceived. And, we need to define our terms in order to really understand caring. And, one of my heroes is Dr. Patricia Benner. Want to thank you for her legacy. She just had a birthday, 79 years old. Thank you, Dr. Benner, for all that you have done to contribute to our profession in your lifetime. You are my hero, and I just want to thank you for your service and your scholarly work. But she wrote in 1989 with Rubel a book titled Primacy of Caring, and she has this definition of caring as a nurse: that the essence of caring as a nurse is that you recognize the value and the worth of those you care for, and the patient and their experience matter to you. I'll say it one more time. The essence of caring as a nurse is that you recognize the inherent value and worth of those you care for, and the patient and their experience matter to you. That's what our students need to really, that's where they need to be that professional. The ASIN essentials, compassionate care, is a competency that needs to be part of their professional identity. Benner got it right on 30 years ago. Let's incorporate that. And what I've done in my practice setting is basically when I had clinical students, I got a couple questions I asked them every time in clinical. I'm going to put it on the board. And they're based on Pat Benner's work, my hero. First question, what is the patient likely experiencing or feeling right now in this situation? That's a question you must ask every clinical as an instructor. Put it in your clinical paperwork. Ask it outright during the course of the day or reflect upon it in post-conference. We must make caring practical. We need to operationalize caring. They just won't get it by osmosis. If anything's important, it needs to be integrated and taught in the curriculum. That includes caring. And my observation has been, as an educator, we just kind of expect them to catch it, kind of like putting it out in the wind and hope they get it. But we don't really operationalize it and make it practical. That's a weakness that I've seen. Let's make it a strength. And that's my goal, to help you, to serve your needs, to do that. So that's question number one. And that gets to the root of empathy. It's kind of like get inside their skin. The second question is this: what can you do to engage yourself with the patient's experience and show that they matter to you as a person? And that's the essence of really that kind of, that's taking Pat Benner's definition and making it a question. Really simple. But I want us to consider us as educators. Could you do this in your clinical? And I really would encourage you to ask these two questions. Put them in your clinical paperwork and really make it a part of that. And so let me just see if there's anybody here that's just, that's just kind of, if I'm just preaching to the choir, or anybody has anything to say. And, Billy says, yes, caring's absolutely central to nursing practice. And Carol says, yes, when you care, you notice and recognize cues. So true. And, Kayla says, another reason I feel that education about burnout and ways to prevent it need to be talked about more. Misty says, as important as pharmacology. You know what I like about that, Misty? And it was a pleasure to meet you at the conference recently. So thank you for your fellowship and collegialship. But you know what? The soft skills are really just as important as the thinking skills. And this is what we're losing, I think, in this next gen. It's all about next gen, and all of the thinking, the 6 steps and all the case study questions. And oh my goodness, the sky is falling. We're not ready. You know what? Let's start with the foundation of clinical teaching. And that's what I'm talking about right now. And that's caring, compassion. And that is just as important as the thinking skills, because caring, compassion, holistic care is the foundation of the framework that we want to build in our students. And as you know, look at a house without a foundation. What happens to it over time? Remember what the house built on the sand or the house built on the rock? Which one do you want your students to be on? And that's why caring and holistic care need to be that foundation of the rock. So yeah, Katie, thank you for sharing. You love the questions. It's my pleasure to share them with you. And just Diane says, I love this. My goal in teaching is to help students learn to love the patients and care. And Diane, that's really, we could have another discussion about, can you teach caring? And, I think we can role model it. We can also expect it. And we can guide our students to kind of, like lead them and show them what caring looks like by our example and by the right questions. We can teach that and move that forward. So yeah, and Carol says, Brene Brown has a wonderful YouTube on empathy. Now, Carol, you're watching this. Could you put that in the chat? Could you go to YouTube in the next 2 minutes and pop that in the chat? Because these chats live forever on the Facebook page, on Keith RN, Think Like a Nurse. And so for those of you that were here today and you found this helpful, the chat goes with it. And you can, bottom line is, those links live forever. So I'd love you to have that if you don't mind. And then Billy says, has a question. Do you have a practical way? Pop it on the screen here. It's a long question. Do you have a practical way to measure if a student is caring to the appropriate level? How can we state on a clinical state this on clinical 2 and measure? Any concrete ways? Boy, I don't know if that'd be a great question for other educators, but what I would contribute is this. If you go to my website, keithrn.com, in the bottom footer, I have a link called Can Caring Be Taught? Or something close to that. And I have Swanson's caring theory that I've operationalized. And Kristen Swanson is another one of my heroes. In 1991, she published her middle range theory of caring based on her work with OB patients, women who suffered miscarriage, death of an infant. And she asked them, how did these nurses show that they cared in her qualitative research? And she identified 5 caring processes and interventions. And I've operationalized those in a way that you can integrate caring and go deeper than just those 2 questions that I did. So for those of you that want to go deeper on that, please go to keithrn.com. It's a free download, and there's a lot of information there that you can use to really operationalize caring. Doesn't measure caring, but yeah, thanks for sharing that, Amy. Can caring be taught? In the chat there. So excellent. And so yeah, there's some great feedback here. And so yes, please go ahead and Misty uses I don't know what you're using, Misty, but I'm glad you're putting that to good use. And so let's kind of get into some of the harder skills, the thinking skills in clinical. So we did a great job in kind of going there with caring and compassion. So now let's finish up with the thinking skills, which are really clinical reasoning skills, is the doing. The doing of critical thinking is clinical reasoning. That's what Tanner's framework is. And even the NCSBN model of the 6 steps of analyzing, of recognizing cues and analyzing cues, those are reasoning steps. And so I want to just point you to a study that Gonzalez in 2018 published called Teaching Clinical Reasoning Piece by Piece. And what Gonzalez did, and this is where I think we need to be moving towards in nursing education with clinicals, because we're not getting the clinical placement time. We're struggling to really make meaningful clinical experiences because not all students get the same experience. We've got to have a structure to clinical. So I'm going to share some really practical strategies now to help you as educators. Maybe think outside the box and let's be innovative, and let's not just do the same old apprenticeship model that we have no evidence to support. We got to keep going there, but let's build on it. And what Gonzalez talked about was taking a clinical 8 weeks, 10 weeks. And in her study, so Amy, I want you to put the link in there from the PubMed, that any educator watching this can look at this abstract and then download the article from their CINAHL database and their academic settings. But Gonzalez had a series of focuses of, this is what this clinical is going to focus on for clinical reasoning skills or nurse competency skills, and had activities in the clinical setting that aligned with the focus. And so, for example, week 1 was on documentation as a nurse and the use of the electronic medical record or the chart to access and collect data that can be noticed. Now, these are nuanced skills that we've got to focus on. The second one was on noticing skills of clinical reasoning. Talk about can we teach a heightened way of recognizing what's relevant or most important. Another clinical reasoning skill, pattern recognition, clustering cues. How is clinical data related to each other? Looking for relationships. That's an analyst. That is the interpreting step of Tanner and that analysis of nursing process. Let's look at that deeper and look at those connections in your clinical paperwork. Look at, for example, with your lab values, the assessment, the vital signs, the H&P, what's connected, what's clustered, what's related. Let's make that a focus in our clinical topic for that week. And so this article is priceless because really what Gonzalez is saying, and I've been doing this intuitively in my clinical teaching, is that you can't just take a big construct like clinical reasoning, clinical judgment, and just kind of expect our students to get it. You've got to break it down piece by piece, whether you use Tanner's framework or even the NCSBN framework. In essence, you're doing the same thing, but we've got to focus and we have to go deep with what is most important. And so talking about problem recognition, nursing process, and the plan of care and priority setting as another emphasis. A lot of great ideas from this article. And so thanks, Amy, for putting that in the chat. And want you all to download that and take a look at that, because that can kind of give you a stimulus, not to just let clinical be random. I think that we just make it, right now it's way too random and we're not getting enough reps. This gives educators in the clinical control. And this is where we can guide this and put this in our syllabus. And let's use Gonzalez's article to help us as educators teach clinical reasoning, essential competencies, and have a focus every clinical in the practice setting. That can strengthen the clinical judgment our students need for safe practice and licensure. So that's just one strategy. But what I also wanted to kind of go there with is basically kind of looking at some essential skills using Tanner's framework, and kind of what even Lasseter's clinical judgment rubric breaks down is looking at how do we teach noticing and interpreting. That's going to be our focus for the next 10 minutes. Because noticing and interpreting, or NCSBN says, recognizing cues and analyzing cues. I will say this. Those are the two most important steps of clinical reasoning. Because if you don't notice well, if you don't interpret well, you're not going to respond well, and you're not going to evaluate well. So this is the foundation, teaching, noticing, and interpreting skills. So what is that? What does that look like, and how can we do that? Well, when we look at noticing skills, we're really wanting our students to notice what's most important. And like I've said before, noticing is prefaced by understanding pathophysiology. This is why our students who memorize the content, memorize patho, but don't really understand pathophys and cannot apply it to fluids and electrolytes, to mechanism of action, to the patient's problem. They're unsafe because they don't have critical thinking. Critical thinking is prefaced on understanding what you know and understand about the content. So therefore, noticing is prefaced on knowing. I want you to write that down. Noticing of Tanner's framework, or if you like the NCSBN, recognizing cues, is prefaced by what you know and understand. So that's why we must make it a priority in nursing education to make sure our students understand the content, not just pass tests, not just memorize, but understand it. That's going to develop the noticing skill. The interpreting skill is a higher level form of noticing, because now what we're doing with interpreting, we're beginning to analyze it, what we noticed. What does it mean? The essence of interpreting is, what does it mean? And what we need to do then is to do some specific skills that our clinical paperwork needs to integrate. So for example, trending clinical data is interpreting at a deeper level. So trending clinical data, whether it be vital signs, lab values, assessment findings, is an interpreting skill that must be taught in our clinical setting. And our students must understand the importance of trending everything that's collected. That's a clinical reasoning skill that's not basically addressed specifically in the NCSBN model. Now, yes, do they expect us to do that? Yes, but we have to break down the 6 steps even further and recognize, when you understand Tanner's framework of clinical judgment and reasoning, and the reasoning steps it represents, that trending is an interpreting skill. Another interpreting skill is priority setting. When you recognize the relevance of cues in clinical data, and then you interpret its meaning correctly, the priorities begin to generate. And that's where the generating hypotheses is really just an additional layer of interpreting from Tanner's framework. So again, clustering data, looking for relationships, is another interpreting skill that needs to be intentionally taught and developed in our clinical teaching. Another skill for our advanced students we need to be very intentional with is determining acceptable ambiguity of clinical data. And as you know, ambiguity is kind of like ambiguous. It means that if a patient has COPD and their sats are 90% on room air, is that okay? Well, it depends. And that's ambiguity. That's ambiguity. But again, if a patient has COPD, they may live at 90%. That's their norm. And then it's recognizing what is, if their norm is already abnormal, like 90% O2 sat, when is it not okay? Is 88% a problem? Probably not. 84% is. But again, these are higher level skills. And I would say that noticing is more of a fundamental skill that we can teach by integrating pathophysiology with the noticing. But interpreting is definitely a higher level skill. And so I really want us to really kind of make that practical. And so what I'm going to be closing with are some practical questions that I've developed. One of the things that I did years ago for my students in clinical who struggled with clinical judgment before we really made it the focus because of Nextgen is simply this. I made how I think as a nurse and using Tanner's framework as a practice-based framework operational. And I want to share with you some questions I've developed that I hope you'll find helpful. And so let's go ahead. I'm just going to pop these on the screen here. Let me see if I have any questions in the chat that I need to answer. And so I see basically ask yourself, what is the true patient's baseline? Yes, Destiny. And so that's a great clinical question that should be in your clinical paperwork. And this is another problem that I want all of you as educators to look at your clinical paperwork like you would a lecture with 70 slides in 50 minutes. Is there infobesity in our clinical paperwork? And really what I mean by that, is it busy work? Is it focusing on the thinking? Or is it focusing on nursing process? Focusing on the traditional care plan? Or is there really high-level reasoning questions that use Tanner's framework and the reasoning that our students require for safe practice? And it should be no more than 6 pages, 4 to 6 pages tops for your first-year students, 2 pages at the advanced level. And I've got examples of clinical paperwork that accomplish that objective in my membership, Think Like a Nurse, that I'll share the link at the end that faculty have access to. And anyone who's got a member, just simply go to clinical tools and look under advanced, look under the different paperwork, under paperwork, and you can download immediately some high level thinking paperwork. That's again, just my best suggestions to do that. And so just want you to know it's there. And so, yeah, and Kayla says, yeah, you're reading my mind, Keith. Yeah, I'm concerned with being able to teach my students how to think like a nurse without overwhelming them. And yes, Kayla, that's called cognitive load. You can only do so much with your prefrontal cortex, and cognitive load theory makes that very clear. Once you saturate, it's dripping on the floor, Kayla, and nothing's retained. And even in our clinical settings where it's high stress, high anxiety, even more so, we must keep it simple and not make the paperwork the God. It's the patient and the thinking and the reasoning we must develop. So anyways, yeah. And so, yeah, I don't know what you used, Karen, where your students said they hate it, but makes me think. But yeah, thinking is foundational. And Anne says this, I teach fundamentals. What advice do you have in helping beginners develop a solid foundation? And Anne, let's get started because I'm going to help you lay a foundation with these questions that you can use to make nursing process and assessment and clinical reasoning practical and actionable. I'm going to preface it with this. Why is air flight flying in a plane so safe? Because pilots use a checklist before they take off, in the air, before they land, and after they land. They have a check, 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 check. What I've developed with my practice-based framework of clinical reasoning, and this framework is found in my membership under clinical tools for the advanced students, it's basically a checklist. And I'm going to share with you the first half of it tonight. I don't have time to do the whole thing. We're just going to keep it simple and not overwhelm. But Anne, here's the answer to your question. So let's go after it. And let me just share these questions for you. These are questions we can basically put in our clinical paperwork. And you have my consent to do so. This is, in essence, my contribution, but my heart is to support and to get the word out and to develop the judgment your students require. Very first question. In one sentence, concisely describe the essence of your patient's story. You see, before we can make sense of the data, and for any level of student, whether you're a nurse or nursing student, you have to frame the data. You have to put a frame around the context of what your patient care scenario is. So the very first step of clinical reasoning is understanding the essence of the story. And it's really simple. It's like post-operative day number 1 appendectomy. 82-year-old male with a history of this. This is their problem. Day 1, day 2, you're done. That puts a frame around everything you collect or a context for the patient's story. Second question. Summarize the what's the current medical diagnosis of your patient, and then summarize the pathophysiology of this diagnosis in your own words. What we're doing now is capturing the essence, pathophysiology, understanding the physiology of their primary problem. Let's say it was appendicitis and it's an appendectomy. And now the third question is this. As you're reviewing the chart, what clinical data do you notice that is relevant? There's Tanner's framework. There's even the first step of NCSBN, recognizing cues, right there. Make it a question. So this is where I would encourage you as educators to look at these questions that the NCSBN is advocating, that Tanner's framework provides, and let's make simple questions. That's really all that I've done here. What clinical data do you notice that is relevant of the lab values, of the assessment, of the H&P, of the last nurse's notes, the most recent vital signs? Is there anything that's out of reference, out of norm, that's a concern? And that's where we as faculty must guide our students to these 3 steps as well. We need to help them capture the essence of the story. Expect them to state the physiology in your own words. Let's raise the bar. Let's have them, let's make that part of our paperwork, and let's see if they can do that. And then making sure that they notice what's relevant. That's where we must guide them as apprentices. Apprenticeship model, I think, is still a good model. We just need to have some more structure to it. So let's go to the 4th question. And this is now under the interpreting kind of aspect of Tanner's framework. Now we're going to ask this question. What's the clinical significance of relevant clinical data? Or other words, what does it mean? What is the meaning or the relevance of this relevant clinical data? That's question number 4. Now we're going to ask question 5. What is the trend of relevant clinical data? See, now we're operationalizing a clinical reasoning skill. And that's what I want you to see it. We are operationalizing the interpreting skill of trending and determining what direction is that vital signs going temp to temp, pulse to pulse, rest to resp, blood pressure to blood pressure. Is it sliding? Is there a concern of sepsis progressing to septic shock, for example? So again, trending is so foundational, and it's an important clinical reasoning skill. It's also going to be the essence of Nextgen. They're going to have single items that are all on trending. Well, let's just teach trending because it's an important skill for practice, not because it's in Nextgen. Let's start preparing our students with the skills of clinical reasoning, first and foremost for practice. We do that well, Nextgen will take care of itself. And so I want to encourage you with that. Next question, question number 6. Do the trends suggest the status is improving, worsening, no change? That's a Nextgen question. More importantly, it's a practice question. As you look at the trends, what's the direction? Where are we going with this? 7th question. What clinical data has a relationship that can be clustered together? This is another high-level skill, probably not for fundamental students, but for our second-year students for sure. Helping them see how data is connected and related together. And then finally, that's also a clinical reasoning skill. And then finally, what additional clinical data is needed to identify the current problem? You're thinking, you're starting to generate some hypotheses. So now we're going to kind of go to step 3 of the NCSBN model, which is really kind of taking the interpreting of Tanner's framework and just building an additional layer into it of what's your hypotheses of your analysis of the data. And now, do I need more data to confirm my suspicion of a potential problem? And so that is the essence of just kind of the 8 questions that I've got. The other 8 to 10, in the membership. I don't have that available publicly at this time, but I'm always willing to share my work. So if you are interested in that actual model, I'd be glad to share that with you. And just go to my, I'll just pop my email you can email me. I'd be glad to help you with that and share that with you. Otherwise, if you're a member, it's in the membership under clinical tools, and that's just the first half. And so I'd just like to know your thoughts on that. Did you find these questions helpful? Could you see that you could use this in your clinical paperwork? And look at your clinical paperwork. Like Tanner would say, reflect. Is this really measuring what's most important? What are we really accomplishing? Are we really developing these clinical reasoning skills that we need to develop? And so I just want to encourage you with that. And yeah, Misty says, yeah, prioritization and noticing, all in 3 steps. I would say 3 questions. So again, as educators, we must always be asking the right questions. And you know what? These questions that I shared with you, they belong in your classroom. They belong in your simulation. They belong as the essence of operationalizing clinical reasoning, using Tanner's framework as the foundation, which again aligns in essence with the NCSBN. So I just want you to see that. And I really want to encourage you to just really take a first step and to be part of that needed change. And so, Anne, thank you. I'm so glad that you found it helpful. Do you think this would be too much for your fundamental students? Are you already laying a good foundation that this would not overwhelm them, these kinds of questions? I think some of them may be, but I want to give you a vision. I want you to get the wheels spinning, Anne. So thank you for joining me tonight. And I'm glad you found this helpful. And you know what? That's the reason I do this, again, is just to shepherd, to serve and support. It's really my heart, and to be a part of that needed change. And so in closing, I want you to know that if you found this series helpful, you found this information helpful, I've got more. Not that I'm trying to, this is just a resource that I published as an outgrowth of my dissertation. And it's a faculty guide to develop clinical judgment. And it's got a lot of information. And I think one of the greatest values of this guide is that, yes, it makes it practical. The things I've shared, it's in writing. You can mark it up. But more importantly, it operationalizes the terms that many of us use but don't really understand, like clinical reasoning, like clinical judgment, like practice readiness. I use the literature to define my terms. And that really will help you as an educator. When you understand that, you'll really have that foundation laid. And so anyways, I just want you to know that if you decide to purchase that and on my website, keithrn.com, if you just use the coupon code, save 20%. It's less than a case study, KeithRN20. And if you'd also like to go deeper, the membership that I offer educators is really unique. It's the only membership for nurse educators that provides the tools that emphasize clinical reasoning. And the essence of my tools, unfolding case studies derived from my lens of practice and those of other educators in specialty topics who I collaborated with that integrate and operationalize Tanner's clinical judgment. I was doing this 9 years ago, way before Nextgen was even on the horizon, because I recognized the value of Tanner's. And so I'm just really thankful that I saw that. and implemented it. And I've got these tools available to you, complete with answer keys and other handouts and tools that I've mentioned that you have my permission to use in your program as a member. And you can, if you're interested in departmental membership, it's even a greater value because you can get a discounted rate and everybody gets access across the curriculum. We need to be using case-based learning. Fundamentals, week 1, they need to recognize that this is a practice-based profession, not a psychology major where you just pass tests. So anyways, I've also got some new resources in the membership. I've got a new section now on next generation NCLEX and other resources that help you to align with that. And I also have a new resource on the membership on the homepage that if you have a tool to share, you just like the Facebook group, you can upload it to the membership and you can put your name on it, your email, describe it, and you can just categorize it. And I want those that are listening tonight, if you've got one tool that would be a resource and you're in the membership, go to my homepage and upload it in the next day or two, because I want to see the membership not just be about Keith RN. And yeah, I've got some really good tools, but every one of you who are listening and are part of that change and are members in the community already, let's share the love. Let's share the learning and the knowledge that we have and our creativity to be part of that needed change. And so it's on the homepage of the membership. Just go to the bottom of the fold and it's right there. It's so simple to use. And I'd love to see some new tools on the membership. So thank you so much. And if you have any other questions, I've got my email here. I'm available to serve your needs in nursing education. So if you have questions or challenges of any kind, any question, I'll be glad to answer it to you, usually within 24 hours. And so next week on Facebook Live, we're doing about clinical judgment in the simulation setting. How can we maximize mid and high fidelity simulation in the skills lab to develop the clinical reasoning skills that lead to clinical judgment? And so look forward to connecting with you then. But let me just look and see what is in closing chats here. Just some questions here so I can just make sure I didn't miss anything. And yeah, Misty, you missed the guide, but you know what? You do have it as a free PDF on the membership. So if you go to my next generation NCLEX section, Misty, on that section, you'll see the faculty guide. It's a PDF. If you want the paper, you can still get 20% off. But bottom line is, it is a free PDF download, the entire faculty guide. So your whole department has access to that. And so Destiny says this: I'm interested in doing a debriefing time after lunch in addition to post-conference after clinical. Should the entire clinical group do a debriefing, or should I just do a one-on-one with the student on the unit? Don't want to overwhelm them. Destiny, it's a great question. After 12 hours, I think you're all tired. The bottom line is, I think that debriefing is just kind of like a Facebook community. It's better together. And I think that you can learn from each other. And if you have the ability to keep them together for 30 minutes and have that time to talk, I think that there's synergy versus one-on-one. It's just going to be, I think, more drawn out and not as rich. So my gut tells me to basically do it together and get other students to share their journey experiences, because we learn from each other, just like we do in these Facebook Lives. You know, we're sharing your insights, some of your tools, some of your insights with other educators. We learn and grow together. Let's do the same thing with our students. And Joyce says this: I've been reading Tanner's book. I am learning so much. Highly recommend it. And Joyce, I'm not quite sure what book you're referring to, but I'd love to know if Tanner has a book. I know she's got the article, but I'd love to know what that is. And so, yes, let me just, Karen says, yes, can I upload my case study there? And Karen, if you're a member, absolutely, please go ahead and do that. And so other than that, yeah, I've got some people there that's going to do that. And thank you so much. And there's no pressure, Destiny, to do whatever you need to do in 30 minutes. But listen, it's been a pleasure to connect with you all today. It's been an hour. It's gone quickly. It's my pleasure to just kind of share what I've learned in my journey and practice in academia and with my PhD studies. I'm so thankful to be done. But again, pleasure to serve. And thank you for joining me tonight. We'll be with you in 2 weeks talking about clinical judgment in the simulation. Thanks so much and have a great week.